Hello everyone, I'm Kashmala Zari, Senior Lecturer, Department of Optometry and Vision Sciences in Superior University, Lahore. Today we are honored to welcome Mr. Khurram Nasir as our guest, national and international keynote speaker and a leading optometry YouTuber in Pakistan. Currently, he is working as an assistant professor in Superior University, Lahore.
Thank you so much, Kashmala, for having me here. And thank you so much for the wonderful introduction as well. And I feel really honored to share my screen with you at this precious platform, Optometry with Khurram. And I can see a diary in your hand right now, and I'm expecting so much questions from you. And you can throw your questions, and I will answer all the questions.
Yes, sir. I'm so excited to ask questions from you. As you know, today our topic is soft contact lens fitting, and I'm going to talk about one simple question. What do you think is the main difference between hard and soft contact lenses?
The main difference is of material, and the material we used in soft contact lenses is, silicone hydrogel and hydrogels. And this material is, this is very soft, and this is very flexible material. The water can or oxygen can transmit through this material from the hydrogel and silicone hydrogel towards the cornea. And this is very good for, the health of the cornea. And the material of the hard contact lenses comparatively is hard plastic material like the PMMA, the polymethyl methacrylate, and if we talk about the precision and comfort of the contact lenses, the soft contact lenses, they are more comfortable. And if we talk about the precision of the visual acuity, then the hard contact lens is the best option for them. So I think this is the answer to the question.
Thank you so much, sir, for explaining it very well. My next question is, to whom should we prescribe the soft contact lenses, and what are the main indications of soft contact lenses?
Very good question, Ms. Kashmala. Actually, the main indications for the soft contact lenses are, the moderate refractive errors like moderate myopia, like moderate, astigmatism. The astigmatism, the regular astigmatism is actually the main indication in terms of astigmatism as soft contact lenses, right? So the soft contact lens can cover the regular astigmatism as well. And the second indication, which is, the cosmetic contact lenses, in soft contact lenses, we have dual options. Like we have power transparent contact lenses as well as, the cosmetic contact lenses. So we have a wide range of colored contact lenses or cosmetic contact lenses in fashion industry, right? So we have gray, hazel, green, honey, different colors in soft contact lenses.
What are the contraindications of the soft contact lenses?
If we have any active infection, like if we have inflammation, if we have the redness in the eyeball, any conjunctivitis, any disorder of the cornea, any disorder of the eyelids, any disorder of the eyelashes, if we have problems with the lashes, with the cornea, with the conjunctiva, with the lashes. So in these situations, in these disorders or diseases, the soft contact lenses or any type of contact lenses, they are strongly contraindicated.
All right, sir. Now we are going to talk about the examination techniques in the soft contact lenses. What are exactly the preliminary examination before prescribing the soft contact lenses?
As far as my practice is concerned, first preliminary examination is for me is the slit lamp examination. So if patient doesn't have any infection, any inflammation, any dryness, so that patient is clean for the contact lens wearing, right? So the first preliminary examination is the visual acuity, right? We will check the visual acuity of the patient, and before this visual acuity, we will consider the history taking as major portion of the preliminary examination. Like what history will tell us, like the general history of the patient, like what is the name, the gender, the profession is very important in history taking, right? And the soft contact lenses history, right? The patient wants, the daily disposable contact lenses, the monthly disposable contact lenses. He needs daily disposable or extended wear, which kind of contact lenses he wants, right? Or the patient has any previous history with the contact lenses, like does that patient has any, allergy with that specific material, has any systemic disease or autoimmune disease which can alter, which can disturb the tear film of the patient's eye, right? And the next is, the visual acuity of the patient. We will check that either patient have any refractive error or not, right? So if patient has refractive error, we will make a full-fledged refraction procedure of that patient. Like we will perform the subjective refraction or the objective refraction. We'll get the proper prescription of the patient, the spectacles prescription, right? And after that, we will change that spectacles prescription into the contact lens prescription. So after that, after that visual acuity, and after that refraction, the parameters of the contact lenses. And you know very well, as an optometrist, you know very well, in soft contact lenses, the diameter of the contact lens, like the base curve of the contact lens, the sagittal height of the contact lens, the water content of the contact lens, these parameters are very important. You know, if we select the proper diameter of the contact lens, you know very well that we can add 2 millimeter in the HVID, right? HVID is horizontal visible iris diameter, right? As you can see in the figure as well, HVID. And for HVID plus 2 will be, you know, the proper diameter of the contact lenses.
All right, sir. Why we add 2 millimeter in the HVID?
The answer is very basic. You know, soft contact lenses are always, you know, flatter than the rigid RGPs, right? So we add 2 millimeter in the HVID. The basic reason or basic logic behind that is, right, we want the periphery of the contact lens or edges of the contact lens, they must go beyond the limbal area, at least 2 millimeter beyond the limbus area, right? For example, if we do not add 2 millimeter in the HVID, the contact lens will exactly fit at the limbal area. And you know very well that if your anatomy is good, if the HVID is actual diameter of the contact lens, it means that the edge of the contact lens will fixate on the limbal area. And you know very well that the limbal area is actually that point where all the arteries which are coming through the heart, which are coming from the heart, they make an anastomosis or ring, right, beneath the limbal area. So there are so many arterial ring beneath that limbal area. So you know very well that cornea got three different mode of nutrition. One is atmospheric oxygen. The second one is, the aqueous humor behind the cornea. And the third one is the oxygen diffusion from this limbus area. So if we put, the edge of the contact lenses, the periphery of the contact lenses at the limbal area, so the oxygen will compromise. The one source of nutrition of the cornea will be compromised, right? And this can cause a hypoxic condition of the cornea, right?
How do we select the base curve of the soft contact lens or the BOZR of the soft contact lens?
The selection of BOZR is very important in soft contact lens fitting, and it always depends on the curvature of the cornea. So the keratometry can give us the K readings, the K1 and the K2 readings, the steep meridian of the cornea, and what is the value of the flatter meridian of the cornea. So how we select the BOZR, the back optic zone radius or base curve of the contact lens, we simply add 0.8 millimeter in the flattest K reading. For example, like K1 is 7.5 millimeter and K2 is 8.00 millimeter. So we will choose the flattest K. 8.00 is flattest K. So we will add 0.8 or 1 millimeter into the flattest K reading.
Okay, sir, do we have a role of water content in the soft contact lenses?
Yes, exactly. The vital role. The water content got a vital role in soft contact lens fitting. Right? We have so many contact lenses like low water content, medium water content, high water content. So high water content will be prescribed in the persons having or facing some issues, some certain issues of dryness. For example, this is my one contact lens, this is second contact lens. This is low water content and this is heavy water content. Which one will be heavier? Obviously, the high water content, right? So in high water content, the lens will be somehow heavier than the normal, right? So a heavier lens will, when this heavy contact lens will insert on the surface of the cornea, so this heavy contact lens, which is having more water content, it will drag like this on the surface of the cornea on every blink. So we have to avoid this excessive movement of the contact lens on the surface of the cornea. And how we can do it? We will increase the diameter of the contact lens, right? You know very well that if we increase the diameter of the contact lens, of the soft contact lens, the contact lens fitting will be steep. You know very well. For example, if the HVID is, for example, 12 millimeter, we will add 2 millimeter and the total diameter will be 14 right? And if the lens design is of high water content, then we will add 0.5 more in 14 Now the total diameter of that high water contact lens will be 14.5 millimeter. And now we have all the parameters of the lens which we have to order from a company, right? And we'll call a company and we'll order that contact lens from that company. But before that, we make some trials of the contact lenses. We will get our, the soft contact lens, trial kit, and we will choose a trial lens from that trial kit, which is exactly same as my diameter, exactly same as my BOZR or base curve, and exactly same as my prescription, right? And if I don't get that contact lens exactly same as my parameters, like my diameter, my BOCR, and my prescription, I will choose the nearest one, right? Nearest diameter or nearest BOCR or nearest prescription as my trial lenses. And I will put that contact lens which is nearest to my parameters, my patient's parameter. I will put that contact lens in the patient's eye and I will make some trials. Either the patient fitting, contact lens fitting is ideal, or it is flat fit, or it is steep fit. Now, if the fitting of the contact lens is flat, the lens is excessively move on the surface of the cornea, we will make it, steep, right? And if the already contact lens, the trial contact lens is steep or tight fit, we will make it, the flatter one, right? So this is how we can use the trial lens kit procedure, right? And if I need to make some changes in my fitting, then I will make, the certain changes, the required changes in my fitting, and then I will order the soft contact lenses from the company.
Very well explained, sir. Now, what do you think will we observe as the contact lens is inserted on the cornea, patient's cornea? What will be the observations that we will do after putting the contact lens on the cornea?
The contact lens is inside the patient's eye, and with that contact lens inside his or her eye, patient has to wait for 10 to 15 minutes, and that is called the settling period of the soft contact lens, right? The patient has to wait, right? After that, after 10 to 15 minutes, the lens will settle on the patient's cornea with all its parameters, like the best diameter, like the best BOCR, like the best prescription contact lenses. And after that, we will ask the patient to sit before the slit lamp, right? And you have, as contact lens practitioner, we have to observe some important observations. And the first thing is that is called, the lower lid push-up test. That is very important, right? We just have to put the observer or the contact lens practitioner will have to put his or her eye at this lower lid, right? Patient will look at the primary position, right? And we have to move our eye like finger like this at the superior gaze like this. If the contact lens is moving smoothly upward with upward movement of my finger, and when I will release the pressure, the contact lens coming back with a smooth precision, right? This is called ideal fitting. And what about the steep fitting? If you put your fingers up, if you move your finger up, number one, contact lens will not move at all, or there will be slight movement of the contact lens, right? This situation is called the steep fitting. And if the lens is already moving on the surface of the cornea, this excessive movement, this is called the flat fitting. So the second observation is, you can say we ask the patient to look straight ahead at the primary position, right? And if the primary position, we have to check two different factors as well. And number one factor is, that is called the centration of the lens. Either the contact lens is well centered on the surface of the cornea or not, right? And the second one is called the corneal coverage, right? If the patient is looking straight ahead in the primary position, if the patient is looking at the lateral gaze, if the patient is looking at the medial gaze, superior gaze, inferior gaze, in any gaze, right? The cornea must be covered with the contact lenses. This is called the corneal coverage. If your contact lens is not covering the cornea in any case, right, then your cornea will face the desiccation. Your cornea will face the dryness, and this is a problem. So we have talked about the lens centration. We have talked about the corneal coverage, and the third important observation is called the lens lag. What is actually the lens lag in layman language? For example, this is cornea, this is contact lens, and right now the cornea and the lens are at their primary position. So if I move the eye in the lateral gaze, the lens will move like this, right? The cornea and the lens will move simultaneously at once, right? And when the eye will come back at the primary position, the lens do not come back, right? This is called lens lag. So we have to observe the decentration and the lens lag at different gazes, right? For example, if the decentration is of 0.2 to 0.5 millimeter at the primary position, so this is acceptable, right? And if your eye is with contact lens, your cornea is at the lateral gaze or at the lower gaze or at the medial gaze or any gaze except the primary position, then 1.5 millimeter decentration or lag is acceptable. These are very important points.
Thank you so much, sir. Amazing. According to my personal observation, when patient is wearing the correct prescription of contact lenses, the visual acuity chart is blurred. But when patient blinks, the chart gets clearer, and after a few seconds, it gets blurred again. What do you think? What is the reason behind this?
So let me tell you one thing that, for example, if this situation is happening with someone, it is actually the indication of the steep fitting, first of all. So I will tell you the logic behind that. And the logic or the reason behind that is, when in steep fitting, the contact lens, when the patient will blink with us, steep fitting contact lens, the contact lens will get centered, exactly the centered of the on the cornea, on the surface of the cornea. And when the lens will get centered on the surface of the cornea, this will make the visual acuity clearer. And the second logic is, for example, you know very well that in steep fitting, there is a space between the lens and the cornea. In steep fitting, there is a space, there is a more gap between the lens and the cornea, right? And the tear film will trap between these two surfaces, right? The lens and the cornea. And when patient will blink, this tear film will washed out, right, from the lens and the cornea, between the lens and the cornea. This will make the visual acuity, more clearer. Let me discuss the similar case scenario with you, and that is, for example, patient is wearing his best corrected contact lens, prescription. He is sitting before the, visual acuity chart, and when patient blinks, right, the all visual acuity charts gets blurred, right? So in this situation, if patient is complaining this kind of complaint, it means the lens fitting is flat. And how? Let me tell you the logic behind that. For example, if the fitting is flat, it means the lens is excessively moving on the surface of the cornea, right? Patient will blink, the lens will move excessively, right? Suppose this is cornea, this is lens. When the patient will blink, the eyelid pressure will comes down and the lens will move like this, right? This excessive movement of the contact lens will make the visual acuity of the patient worst.
Thank you so much, sir. I enjoyed your talk and valuable insights about soft contact lens fitting a lot. And I'm hopeful that we will have more sittings on many different topics on this precious platform of Optometry with Khurram, inshallah. And thank you so much again.